Hello and to the attendings of CardioCon 2022. It's a pleasure to virtually be here, and it is a huge honor to be invited to give my talk on cardio-oncology to you and your colleagues here in India. My name is Eric Yang. I'm a clinician educator at UCLA, and I direct a UCLA cardio-oncology program. And I want to thank the organizers, in particular Dr. Sharma and Dr. Parvani, for the opportunity to present one of, I believe, to be a growing issue amongst the cancer population, not just within India, but throughout the world, in a case regarding HER2-positive breast cancer and concomitant cardiovascular disease, and how to gauge the unique nuances of cardiotoxicity related to any potential cardiotoxic treatments they may receive. And this will be in the form of a case presentation, and I am excited to hear some of the feedback from the audience. So we shall proceed. Here are my relevant disclosures, none of which are financially relevant to the content of this talk. So the objectives of this case presentation are to do several things. One, to have the audience understand the relevance and importance of recognizing and treating cardiovascular toxicity and disease in the growing cancer population worldwide. And although the field is very rapidly moving and we still have ways to go on really generating robust evidence-based guidelines on the diagnosis and treatment and surveillance of cancer treatment-associated cardiotoxicity, I will review what we have so far in our literature in the past couple of years on how to best serve these patients. And finally, how can we integrate these evidence-based approaches to day-to-day clinical practice, particularly in this example of a breast cancer patient, in being able to effectively treat and risk stratify cancer patients and survivors with pre-existing cardiovascular disease or acquired cardiotoxicity. So my outline will be two major sections. First, this one patient case scenario and an overall commentary of whether knowing the field of cardio-oncology matters. For those of you in the audience who are not familiar with this term, I will go into this multidisciplinary field in more detail. And also from what we know about how to care for these patients with a review of recent society expert consensus statements. So first, let's go straight into the case. So I'm going to give a more conventional history and physical, or assessment, if you will, perhaps coming from someone who is a traditional cardiologist. So we'll call it a non-cardio-oncology assessment, someone that would normally take a history seeing someone with known coronary disease. So we have a 55-year-old female coming to your clinic with a recent diagnosis of left-sided breast cancer requiring chemotherapy and radiation, of which you're not really sure what it is. She herself is not very physically active and walks maybe a couple times a week leisurely or as part of her activities of daily living or to go to the grocery store. She doesn't elicit any symptoms. Her past medical history is certainly significant for a history of myocardial infarction 2 years prior. She had a stent placed in her right coronary artery, and also dyslipidemia and a decade history of type 2 diabetes and hypertension. Her family history is significant for a father who underwent coronary bypass surgery at the age of 65, and her medications, as you can see, are here with aspirin 81, metoprolol tartrate 25 milligrams twice daily, atorvastatin at 10 milligrams daily, metformin twice daily, and a small dose of lisinopril. Her blood pressure, at least in clinic, is mildly suboptimal at 135/82, with a BMI of 29.8, with overall an unremarkable physical exam, normal jugular venous veins, no obvious peripheral edema, clear sounds, heart sounds, and clear lung sounds. Her lipid profile is here below, and I believe I have the right units for the South Asian population here. But her LDL, as you can see, is not particularly optimal in that it is still elevated at 110 on a moderate intensity statin. Her hemoglobin A1C is somewhat near control at 6.8%. What is also notable that her NT-proBNP is elevated at 1600 nanograms per deciliter, and her ECG shows evidence of an old inferior infarction consistent with her history. Films from her angiogram, you could see here ruptured plaque with hazy appearance of her mid-right coronary artery here, seen in multiple views, requiring also temporary pacing at the time of her myocardial infarction. And her ejection fraction prior to treatment still showed a long-standing, mildly depressed LV ejection fraction of 46%, a dilated right ventricle with low normal function with inferior and inferior septal hypokinesis. So what I went over is something a cardiologist would ask. But then the question is, what would you do if you actually knew more information or the nuances about the breast cancer? And let's say you were able to get that information and you found out that this poor woman was diagnosed recently with left breast carcinoma, and genetic testing revealed ER positive or PR positive, as well as HER2 positive stage 3 breast cancer. So we can call it a triple positive. And her cancer doctors propose, in an ideal situation, if not for her heart disease, neoadjuvant TCHP, also including the drugs docetaxel, carboplatin, trastuzumab, and pertuzumab, or also known as dual 2 anti-HER2 treatments. In the modern era now, with this kind of early breast cancer, no anthracyclines proposed, but also followed by a radical mastectomy and subsequent radiation treatment to prevent recurrence. So some of these may pose potential short and long-term cardiotoxic risks, but the question is which ones do and which agents should you be worried about? And this, case probably fits the milieu of many of your patients without the cancer. But now there's an additional element of potentially a patient that may have a survivable malignancy, but then her oncologists may potentially hesitate or be reluctant to continue some of these traditional treatments because of her pre-existing cardiovascular history. And then the big questions that come up to both sides of the cancer and cardiology team members of her care might include, the question of which following risk factors predispose her to cardiotoxicity during treatment: her coronary disease and prior history of myocardial infarction, and the fact that she does have evidence of diastolic dysfunction and elevated filling pressures with her BNP levels, and heart failure with mildly reduced ejection fraction. And also, given that her EF is below 50% by echo, is it safe to give her anti-HER2 treatments? Or, do you just give one, or do you continue with both agents nowadays with modern treatment guidelines? And what protects the heart during this? What's known to be effective? And then how do you watch her during treatments? What's the surveillance strategy? What's the long-term surveillance strategy? What's the best way to do it? MUGA, echo, cardiac MRI? And then what's the long-term risk of radiation treatment that she would benefit from on cardiovascular event rates? So switching over to recent society expert consensus statements, and I put this with a big asterisk that a lot of this is still based off of expert opinion because we still lack widespread randomized controlled trial data compared to our interventional and electrophysiology colleagues of thousands and thousands of patients being studied. But before I go on, I do want to review really the fundamental tenets of cardio-oncology, which is a growing field internationally and has growing programs in India and throughout Asia, and also has been very firmly established in the United States. And it really focuses on three major factors of the cancer patient: the interplay of cardiovascular risk factors and disease, the cancer biology and the disease itself and how it can affect one's cardiovascular risk profile, and the cancer treatments that occurred in the past, if they come to you as a survivor, or what they are going to get. And this intersection of this Venn diagram correlates to the possible effects of treatment-related cardiotoxicity, where if it happens acutely, it can certainly affect access to life-saving drugs. And then chronic toxicity, number two, can certainly affect still quality of life and long-term survival and morbidity. In fact, you will learn that many cancer survivors, the top causes of death are usually cardiovascular disease. And what makes this field so incredibly rewarding, intriguing, and interesting, but daunting, is that in every patient, this combination changes very differently based on the cancer, the stage of cancer, and the type of treatments, and also the pre-existing risk factor profiles that they present with. And why we think cardiotoxicity occurs overall stems from this general theory of what we call the multiple hit hypothesis. And this paper, described by Dr. Lee Jones at Sloan Kettering, talked about how pre-existing cardiovascular risk factors in general make the likelihood of suffering cardiovascular injury during chemotherapy or cancer treatments makes the overall risk of further exacerbation of cardiovascular disease much higher. In fact, if you get cancer treatments, not only does the treatment themselves cause ongoing potential cardiac injury, but the indirect effects, the fact that you can't exercise as much, your cardiovascular reserve suffers, you can't stay on your medications for your cholesterol, your high blood pressure because of liver dysfunction, or renal failure from dehydration or anemia. These are all things that we don't have really good evidence-based guidelines as to whether this is appropriate to continue in cancer patients because these were never studied in the original trials in cardiology. And at least within the United States here, you could see that by the year, currently there are about 3.8 million survivors here, but studies of our population shows that if you are a breast cancer survivor and you have lived more than 10 years, you are more likely to die from cardiovascular disease than you are from recurrent cancer or cancer-related causes. And yet, despite advances in treatments, the incidence of cardiotoxicity in modern trials still remains not insignificantly low. You could see here with some early trials here, ranging from Dr. Cardinali's prospective look at anthracycline cardiotoxicity of EF drops that were significant, as well as the long-term effects of heart failure with adjuvant chemotherapy with or without trastuzumab. The risks of heart failure remain elevated, as well as a modern European cardiotox registry that the likelihood, thankfully, of severe LV dysfunction remains low, but even mild LVEF decreases still were rather common. And the 60 trial, which also focused on a low-risk Brazilian HER2-negative cohort getting anthracyclines, the incidence of both arms getting beta blockers or placebo remained elevated from 13 to 14%. So going over what are some of the risk factors that make you concerned about potential issues of cardiotoxicity, meaning that this could cause cardiovascular dysfunction during cancer treatments. And you can see that the patient I discussed already has some of these issues already, including her being hypertensive. She may have an abnormal LVF baseline, less than 50%, and pre-existing diabetes. And then some, and I don't have time to go over it all, but many of these agents that have been tested or studied in cardio-oncology trials here, you can see a variety of ACE inhibitors, angiotensin receptor blockers, statins are being tested, as well as certain classes of beta blockers. And essentially, it also points to the fact that neurohormonal agents, although a meta-analysis did not show a clinically significant effect, it certainly warrants aggressive use to prevent the onset of long-term cardiovascular risk. And the best we can do right now is extrapolate what we know from traditional heart failure literature to also do what we can to lower one's risk factor milieu. And although this meta-analysis of 17 trials does suffer, unfortunately, from significant heterogeneity, but there does show a non-significant trend towards lower adverse clinical events, and subsequently further studies are warranted. Now, the other question is that if you already have underlying heart failure, is it safe to undergo trastuzumab or anti-HER2 treatments? And while we still have very small studies showing this, historically it was thought to be forbidden or you would have your cancer doctor stop treatment. But there are some phase 1 trials, including the SCHOLAR trial, which was published in JACC Cardio-Oncology 2 years ago, looking at a phase 1 prospective single-arm study of 20 patients, all of which of note did receive anthracyclines, but they were eligible if their cardiac function dropped to less than 40% or more than 15% from baseline. And subsequently, they were all put on aggressive goal-directed medical therapy with beta blockers and ACE inhibitors. And they found that 60% of patients were actually able to tolerate both medications. And even the better news is that 90% of patients were able to continue all of their treatments. And nobody died during this study in terms of related to cardiac failure. And essentially, only 10% were not able to complete this. So this was a very promising look to show that if you developed cardiotoxicity during treatments, if you were closely followed and you had very aggressive uptitration of heart failure medications, there was a good likelihood you could continue your life-saving treatment. And the other question of whether you should use 2 agents or 1 agent with anti-HER2, especially if there's concern for underlying cardiovascular dysfunction. So this was a meta-analysis that we performed also with Dr. Daryl Leong at McMaster University's leading this study of a meta-analysis of approximately 8 high-quality randomized controlled trial studies looking at pertuzumab versus placebo. And one of the endpoints we looked at was whether or not pertuzumab had an effect on asymptomatic or minimally symptomatic systolic left ventricular dysfunction. And the overall cohort of approximately about over 44,300 patients, there was no statistically significant signal to suggest that pertuzumab added more harm or more cardiac insult based on multiple randomized controlled trials. And then now turning over to cardiotoxicity surveillance strategies. And this was a paper that was just published in the European Society of Medical Oncology, looking at this algorithm of overall potential cardiotoxic mechanisms and medicines, and how you should risk stratify a patient based on their cardiac function by their LVEF. And in this case, you have a woman who has probably mildly reduced or low normal features. And then the question then becomes, if you can't consider alternative non-cardiotoxic treatments, as anti-HER2 treatment is really the best way for her to ensure her survival, then it is very important to initiate or up-titrate cardioprotective therapy and also continue cancer treatment with close monitoring. No longer is it really the situation where it is forbidden and you can stop. In fact, we should be aggressive, just as the cancer doctors are, in trying to attenuate their cardiovascular risk while they get life-saving cancer treatments. The American Society of Echo a few years back also had an algorithm of how often one should be screening for cardiotoxicity. And while the model they use, the type 1 and type 2 toxicity, I believe is flawed and oversimplistic, it is probably best to substitute type 1 with anthracycline-based regimens and type 2 with anti-HER2-based regimens, not including all the other classes of tyrosine kinase inhibitors, because that has not been studied in the same fashion as anti-HER2 treatments. But briefly going over anthracyclines, which is not applicable to this patient, but it's important to not only get cardiac LVEF assessment at the beginning of treatment, but also it's very important to get it at the end of treatment and within 6 months, because that is when the ejection fraction, the majority of ejection fractions, if they do decrease or they drop, this is the time to check. And this is very important to do so. Other additional things to improve the quality of your studies or your surveillance include using echo contrast or using 3D technology if you have access to it, global longitudinal strain, and biomarkers such as troponin I prior to treatments. Now, with anti-HER2 treatments, like our patient, it is important to look for ongoing or the development of cardiac dysfunction, although the risk of it happening during, without anthracyclines is very low. It is important to also check ejection fraction every 3 months during treatments. On the long-term treatments are not usually, long-term surveillance is usually not indicated after treatments unless you combine it with anthracycline therapy. And if the ejection fraction or the global longitudinal strain drops below a certain amount in the LVF of 53%, or the global longitudinal strain that was in the lower limit of normal, then it is reasonable to refer to a cardio-oncologist for further care and up-titration of health. Now, moving on to radiation treatments. And this is still used commonly in up to more than 50% of cancer patients, especially in breast cancer, as there is associated with a 50% reduction in disease recurrence and reduction in death. It is also used less so now in Hodgkin's lymphoma, but other hematologic malignancies. In general, nowadays, compared to older techniques, overall decreased radiation doses have occurred due to improvements in more precise CT planning systems and other techniques, but we have yet to know whether or not this truly reduces cardiovascular event rates. We do know historically that breast cancer and Hodgkin's lymphoma radiation survivors are at higher risk for ischemic heart disease and cardiac death. Really, one of the most prominent epidemiologic studies was published in 2013 by Dr. Darby and colleagues, which was a Scandinavian cohort looking at over 2,000 women who underwent radiotherapy for approximately 4 to 5 decades in Sweden and Denmark. And they compared women who had major coronary events and to their controls. And they also derived that anyone who got left-sided radiation, and they also extrapolated this to the radiation doses to the presumed left anterior descending artery. And the overall mean doses to the whole heart was 4.9 grays, which is probably about the same that our woman in question would get. And the rates of major coronary events increased linearly with a mean dose by heart by 7.4% per gray. And this increase started within already the first 5 years after radiotherapy and continued into the third decade. And also, if you included other cardiovascular risk factors, hypertension, disease, age, your risk of cardiovascular event rates would exponentially go up. Thus, really again emphasizing the need for aggressive risk factor modification and aggressive control of risk factors such as diabetes, blood pressure, and lipids. And another thing that I also advise my trainees as well as our colleagues now is that CT imaging, which is done for many cancer patients, it gives you, to a sense, free cardiac data. And this is an example of a CT simulation breast of a woman who had radiation therapy about a decade prior with left-sided breast cancer, which you can see on the CT. But really, as a cardiologist, what I'm really struck by is really the heavy calcification seen here. This does not necessarily warrant invasive treatments, but it does tell you whether or not this patient should likely be on aggressive statin therapy and presumed secondary prevention. But going back to our patient finally, so the question then becomes, what do I recommend as a cardio-oncologist? Well, some of this is based off of opinion and from what we know from the limited evidence. But again, going back to, going from a conservative, sort of prohibitive mentality of saying, oh, you can't get these treatments because you have risk factors or you have cardiac disease, there are risks that exist. But in my opinion, in my mind, and to many of our cardio-oncologists, such things are not necessarily prohibitive. If she is going to die of her breast cancer without adequate treatment, then it is the cardiovascular disease, frankly, is a minimal point of discussion, or really there's not much that needs to be focused on when it's more of an important prerogative to let her get her cancer treatments, even if she does get cardiotoxicity. So it is important to counsel the patients on being aware of potential symptoms of heart failure and also long-term risks of radiation treatment. Obviously, there is risk that it could exacerbate her cardiac event rate in the future, but if it also provides her a much higher chance of remission, cure, and survival, then it is certainly something that should be considered. What I would do during my time taking care of her would be to change the beta blocker to a more studied drug such as carvedilol, which also may potentially have some afterload blood pressure lowering properties, up-titrate her lisinopril aggressively to get her blood pressure below 130/80, and also change her atorvastatin to a high intensity with a goal LDL of less than 70. Some other things that also I would encourage her to do is that, given if her prognosis is good, is to really focus on activity, physical exercise, and not to just frankly become sedentary and suffer the side effects of her treatment, but to truly restore as much normalcy as possible. We also know that breast cancer survivors also have better prognoses based off their exercise capacity, even after treatments. And even those who are cured of cancer who have poor exercise tolerance fare very poorly in the near future. And in going to the big question of whether TCHP should be done, my answer is yes. And obviously you would need very careful monitoring and doing echocardiography with the highest quality you have available with image modalities that you have available at your institution, including that with contrast or with 3D every 3 months until the end of treatment. The long-term surveillance of this, unfortunately, is unknown with anti-HER2 alone. It is reasonable to perhaps repeat imaging in the future, but usually long-term isolated LV dysfunction with anti-HER2 therapy by itself without anthracyclines is likely unlikely. And only stop if heart failure symptoms develop and or drop with an ejection fraction greater than 10% with careful, high-quality imaging, as I stated before. So in conclusions, the field of cardio-oncology is a dynamic field that is increasingly relevant to a growing cancer population and to survivors worldwide. And really aggressive management of cardiovascular risk factors and prognostically favorable cancers, such as stage 3 and below breast cancer, is key to potentially reduce the risk of cardiotoxicity and the worsening cardiovascular disease. Cardiotoxic but life-saving treatments can be given in high-risk individuals, really with good risk-benefit discussion and careful imaging and monitoring for symptoms and optimization of cardiovascular medications. And finally, concomitant multidisciplinary care of cancer patients with cardio-oncologists can potentially attenuate cardiotoxicity and long-term cardiovascular effects, along with morbidity and mortality. Once again, I'd like to thank the organizers for this opportunity to talk about this case and the field, and I'm happy to discuss afterwards and answer any questions. Thank you.